Uh, Namaskar and hello to today's journal club. So this is our third journal club, and we are happy with your viewing and that you are learning about different kind of studies. And this is for the students as well as our young intensivists because studies have to be learned to one has to learn to analyze the studies, and of course the students have to pass the exams with different kind of studies. So again, today the presentation will be from All India Institute of Medical Sciences and will be presented by Dr. Minupriya. She is a DM resident at All India Institute of Medical Sciences, New Delhi. And again, it will be moderated by the same people. Dr. Jitendra Sharma, sir is Chief of Critical Care at AIIMS Hospital, Gurgaon. And sir, Dr. Bikash Ray, sir is Additional Professor at All India Institute of Medical Sciences, Department of Critical Care and Anesthesia, AIIMS, New Delhi. So the trial for today has been selected from intensive care medicine. It is a recent trial. The heading is long-term effects of flexible visitation in the intensive care unit on family members' mental health. A 12-month results from randomized clinical trial. So something slightly different but very important because the mental health is very important for not only the patient but also for the family members, and we have to give best kind of care in terms of mental health. And this is a different design. It's a sorry, it's an analysis of a cluster crossover randomized clinical trial. So it will be presented by Dr. Minupriya and it will be analyzed by Dr. Jitendra Sharma and Dr. Bikash Ray, and there will be some question answers as we go along just to keep everything interactive. So over to you, Dr. Minupriya and Dr. Jitendra Sharma and Dr. Bikash Ray, sir.
Thank you, Dr. Please, Dr. Meenu, you can share your screen. Yeah, you can start.
Yes, sir. Good afternoon, one and all. I'll be presenting the trial titled Long-Term Effect of Flexible Visitation in the Intensive Care Unit on Family Members' Mental Health, a 12-month results from a randomized clinical trial from the ICU Visitation Study Group investigators affiliated to the Brazilian Public Federal Research University. This trial was published in Intensive Care Medicine in August 2024. Coming to the introduction, the ICU Liberation Bundle, which is the A to F bundle, it is consists of a group of practices which are directed at improving the care of patients who are the ICU survivors by liberating them not only from pain, delirium, mechanical ventilation, immobility and isolation, but also from post-discharge sequelae like the post-intensive care syndrome and the post-traumatic stress disorder. Post-intensive care syndrome consists of decline in the physical, mental and the psychiatric components of the patients post-ICU discharge. And this post-traumatic stress disorder is one of the spectrum of the post-intensive care syndrome. The family element of the ICU liberation bundle aims at involving the family in the patient care to help them recover from the critical illness. The goals are providing both physical and also emotional support to the patients and the family members by actively involving them in the patient care. This has found to decrease the delirium and the coma days by 25 to 50% and also reduce the ICU readmissions by 50%, thereby having a positive impact on the quality of recovery of patients. A study was conducted to know the perspectives of the healthcare professionals on the flexible ICU visitation policies. It was found that all of them had a belief that it reduces the risk of delirium and anxiety in patients and family, but they also had some negative perceptions or beliefs, like they thought that allowing flexible ICU visitation might increase the infection risk. They also feared patient exhaustion, interference with the delivery of care to the patients, and clinician on staff burnout. The evidences from the observational studies on the flexible ICU visitation model showed that there was a significant reduction in the patient and the family significant improvement in the patient and the family satisfaction, decrease in complaints and anxiety with the flexible ICU visitation models. And against their belief, negative perceptions, the evidence showed that there was no infection risk, no patient exhaustion, or no increase in ICU mortality with the flexible visitation models. This is a systemic review and meta-analysis comparing the flexible versus the restrictive visitation policies in ICUs, which involved 7 studies, out of which 2 were RCTs and 5 were observational studies. This mainly compared the patient outcomes. Like, it was found that flexible visitation policies reduce the frequency of delirium and the anxiety symptoms in the patients without increase in the mortality or the risk of ICU-acquired infections, which was against the belief of the healthcare professionals. Like the patients who suffered from intensive care syndrome, the caregivers also have some component of the post-intensive care syndrome called as the PICS-F. It is found to be in 50 to 73% of the family members. The risk factors are by witnessing the emotional distress of the family members, patients, and a subjective sense of burden, financial constraints of the family members led to symptoms of post-traumatic stress disorder. So why this topic became important is because when the family members are affected by this component, it may compromise the patient's rehabilitation potential and sustainability of home care, because the family members are needed for the continuum of care of the patients at home also. So since this topic became a topic of interest, researchers started evaluating the mental health of caregivers. This is a study published in NEJM in 2016. Which is an observational study in which 1 year outcomes of caregivers of critically ill patients were evaluated. 280 caregivers of patients who received at least 7 days or more of mechanical ventilation in the ICU were observed. They were assessed at 7 days, 3 months, 6 months, and 12 months interval after ICU discharge of the patients. It is found that this is the epidemiological scale used for depression. It was found that almost 67% of the caregivers had depression initially in 7 days, and up to 43% of them continue to have depression even at 1 year. So owing to this high level of depression existing in caregivers, the society guidelines have endorsed flexible ICU visitation hours as an important strategy to overcome this post-intensive care syndrome to improve patient and family-centered care. Though society's guidelines have endorsed flexible ICU visitation hours, still there is a lack of practice in various countries in which the flexible visitation hours were followed in less than 20% of the countries only. The current study which we are going to discuss comes from Brazil. In their country, the practice was up to 2.6% only. So the study investigators, which is the ICU visit study investigators, they were interested in studying the effect of flexible ICU visitation models. They are a group of investigators from various centers of excellence in Brazil, from various disciplines including intensive care, epidemiology, critical care nurse, and physiotherapists. They initially conducted a before-after study with the ICU flexible ICU visitation model. In 2017, it was published in Critical Care. Later on, another study, which is the ICU visits randomized control trial, published in JAMA in 2019. These two studies mainly study the effect of the flexible model on the incidence of delirium of patients. Later on, the current study which we are going to discuss came up, in which they followed up the family members of the patients after 12 months of ICU discharge to study the incidence of post-traumatic stress disorder in the family members. So this is the forerunner of the current study, which is the ICU visit randomized clinical trial. We studied the effect of flexible family visitation on delirium among patients. The population involved were around 1,685 patients, and the family members of the patients were involved, and 737 clinicians were recruited. The intervention given was flexible visitation up to 12 hours per day, along with family education, and the control group received usual restricted visitation up to a maximum of 4.5 hours per day, and the median was 1.5 hours per day. Their primary outcome of interest was the incidence of delirium in patients. So it was found that there was no difference in the incidence of delirium or ICU-acquired infections or staff burnout. They studied the effect on family members as a secondary outcome. In that, they found that there was a significant reduction in the median anxiety and depression scores of the family members who received the flexible visitation model. So this study was conducted as a continuum of this ICU visits RCT involving only the family members. That is, the 1,060 family members were followed up, and their outcome was used as the primary outcome. The rationale was for conducting this long-term follow-up is that most of the evidences till now on the flexible family visitation model comes from underpowered observational and before-after studies. And though one RCT was conducted, which is the ICU visit study, it also studied only the short-term outcomes like the depression and anxiety of the family members. There is no randomized clinical trial till now which studies the long-term effects like the post-traumatic stress disorder. Hence, the authors of this study wanted to study the post-traumatic stress disorder of family members, and their hypothesis was flexible visitation policy in the ICU supported by family education will reduce the prevalence of post-traumatic stress disorder at 12 months among family members of patients discharged from ICU. Coming to the methodology, trial design and oversight. It is the long-term outcome analysis of the ICU visits trial, which was a multi-center cluster crossover randomized trial. It was registered in clinical trials before initiation. They obtained approval from the Institutional Research Board at Brazilian Research in Intensive Care Network, and funding was given by the Brazilian Ministry of Health. The consent process was a mixed consent at the cluster level, that is the ICUs. Consent was obtained from the hospital director or the head of the ICU. Among the family members, they followed the same family members who were involved in the ICU visit trial. They were contacted telephonically over phone after 12 months of the patient discharge, and consent was obtained over telephone. Among the patients, the need for informed written consent was waived in 33 ICUs, stating the reason that they didn't follow any new intervention which is going to affect the patient directly. It was mainly involved in the organizational changes, like the visitation policies. So they waived off the consent in 33 ICUs. It was also overseen by an independent data and safety monitoring board. Inclusion criteria, the trial included 36 ICUs in Brazil. Among the clusters, that is the ICUs, adult medical and surgical ICUs were included, including ICUs from public and private non-profit hospitals with at least 6 beds, and a restrictive policy of ICU visiting hours, less than 4.5 hours per day before enrollment in the study. Among the ICU patients with age more than 18 years were included, and family members, the closest family member of one per patient were included. Exclusion criteria included family members with difficulty in communication or comprehension of the language, inability to contact via telephone, refusal of the family member, incomplete outcome assessment by the family member. Randomization. The unit of randomization in this study was ICU, that is clusters. It was done by a blinded statistician in a 1:1 ratio. They used variable size blocks. Stratification was done using a number of ICU beds as the criteria to equally distribute that number of beds also in both the groups. The trial group assignments were concealed using sequential numbered opaque envelopes. Clinicians involved in the patient care were not blinded to the trial group assignments because they came to know the visitation policy once the ICU was enrolled. The researchers conducting the telephonic interview for the family members were blinded. The trial interventions were the flexible family visitation model compared with the restrictive family visitation model. In the flexible family visitation model, 1 or 2 close family member was enrolled in the telephonic interview. They were allowed for flexible visitation up to 12 hours per day. Family member education also was provided additionally with structured educational meetings. And they also allowed social visits at specific time intervals. Like apart from the family member, any friends or relatives can visit the patient at the specified time interval according to the local rules, like in the restrictive family visitation model, where visiting hours were limited and family and social visits both will happen only during that time. So the hours which were limited were as per the pre-study hours in that ICU, which was followed prior to the study enrollment also. The trial interventions in the restrictive family visitation model, only social visits were allowed in the restricted hours up to 4.5 hours per day. Whereas in the flexible visitation models, along with social visits, family visits were also allowed up to 12 hours per day. And in the restrictive visitation model, only some printed information were given about the patient safety or any procedures to the family members. Whereas in the flexible visitation model, the family members were involved in information meetings which were related to the patient's care and also the ICU environment, the routine practices in the ICU to provide better communication and understanding of the care in the ICU. And also they were involved in they were provided access to the website focused on education about the same. Trial interventions which were common to both the models were standard care practices which were followed. Like when any procedure was performed for the patient, the family member was requested to leave and then come back to the bedside. And long visiting hours were permitted in some extraordinary cases, like in cases of terminal illness or then when there were conflicts with the ICU team. Long hours were permitted apart from the protocol recommended hours. This is the overall representation of the study in which the ICUs, medical and surgical ICUs, were randomly allocated between flexible family visitation and restrictive family visitation models. Before allocation, they were given a 15-day learning period for the ICU members to adapt to the new policy which is being implemented before starting the outcome outcome variables recording. So after that, the outcome variables were evaluated from the patient's family members in the ICU. This is actually in the ICU visit study. So after phase 1, they allowed a 30-day washout period before crossover to the other group to avoid any carryover effect. And later on, the study, this long-term analysis was done 12 months post-discharge of the patients by contacting the family members over telephone. Methods. The primary outcome of the study is the prevalence of post-traumatic stress symptoms in the family members, which was measured using an impact of event scale. So this is a 6.6 item scale in which a mean item score of more than 1.75 was used to define the presence of post-traumatic stress disorder. In the secondary outcome, the prevalence of anxiety and depression was measured using the hospital anxiety and depression scale. This is also a 14 multiple choice questionnaire having 2 subscales with each subscale having 7 questions each. And a cutoff point of more than 7 was considered as possible clinical anxiety or depression. And a cutoff point of more than 10 was considered as probable clinical anxiety or depression. The secondary outcomes also included mean scores of the post-traumatic stress disorder, anxiety, and the depression scores. Data collection was done by telephonic interviews by trained researchers who were not involved in the direct care of the patient during the ICU stay. And it was done at a 12 months time point post patient discharge from the ICU. A designated relative was contacted by phone. If they gave consent, then assessment was done using the questionnaires that we saw earlier. The data on the length of stay of the visitor at the bedside was collected prospectively once they agreed to participate in the study. Statistical analysis, separate sample size was not calculated for the study. The same sample of family members which were recruited in the ICU visit trial were followed up. A total of 1,060 family members of the 1,685 patients recruited in ICU visit trial were followed up. In the ICU visit study, a power of 80% was used to detect an absolute difference of 6% in the incidence of delirium with a two-sided alpha of 0.05. The primary analysis was done using generalized estimating equations, adjusting for the cluster effect since a cluster of ICUs were involved in the study, and the period effect also. The categorical variables were presented as prevalence ratio with 95% confidence interval. The continuous variables were presented as mean difference with 95% confidence interval. Subgroup analysis was done for predefined subgroups like sex, age, history of anxiety or depression, surrogate decision maker role, whether the family member lived with the patient's vital status, Apache to score within 24 hours of inclusion in the study, the length of ICU stay of the patient. Then post-hoc sensitivity analysis was performed for adjustment of covariates which were not included priorly, like the education attainment of the family member, the monthly household income, and the unemployed or the retired status of the family member. Coming to the results, the participants were, that is the family members, were followed up from July 2018 to March 2019. A total of 1,060 family members were assessed for eligibility, who were the family members who were recruited in the ICU visit trial from 36 ICUs in Brazil. The characteristics of the participating ICUs were in the flexible visitation model, a total of 19 ICUs were recruited, and in the restricted visitation, 17 ICUs were recruited. It included both public and private non-profit hospitals. In both the groups, before the enrollment in the study, the median visitation hours were 1.5 hours only. So this is a consort diagram showing the 1,060 family members who were initially assessed for eligibility. Out of them, they were contacted telephonically, and it was found that 244 patients in the flexible model and the 297 patients in the restrictive model lost a follow-up because of reasons like they were not able to contact them telephonically, or they refused to participate. And some of them have communication difficulties, and after 10 attempts of failure in contacting the participants, they were excluded from the trial. So 288 participants were included in the flexible model, and 231 participants were included in the restrictive model. This table shows the characteristics of the population study. That is the characters of the family members. The median age, which was found to be 46 in both the groups, and the 70%, around 70% of the participants were females. Around 30% of them had received higher education, and the median, and 30% of them had unemployed or retired status. The median household income was falling in the range of upper middle to lower middle class income ranges. And the previous history of anxiety and depression occurred in 13% in the flexible model and 14% in the restrictive model, which were comparable in both the groups. Other characteristics like living with the patient, surrogate decision maker were also comparable between both the groups. This table shows the characteristics of the patients. So the median age of the patient was found to be around 60, and around 45% of the patients were females. The type of ICU admissions were also comparable between the groups, out of which around 35 to 39% of the patients were medical admissions, and around 50% of the patients belonged to surgical admissions, and other admissions were from trauma and neurocritical. The median Apache score of the patients were around 12, and the length of ICU stay was around 5. Median ICU stay was 5 days in the flexible model and 4 days in the restrictive model. The vital status at 12 months alive status of the patients were around 75 to 76 to 77% of the patients were alive at 12 months post discharge. Since around 50% of the study participants were excluded, they also published the characteristics of the participants who were excluded from the study. In this table, it is found that almost all the characters were similar in the included population and excluded population, except for the history of anxiety and depression, which was higher in the flexible patients excluded from the flexible visitation as compared to patients excluded from the restrictive visitation model. Coming to the outcome results of the outcomes, the primary outcome is the prevalence of post-traumatic stress symptoms. So, score of the impact scale of more than 1.75 was considered as a presence of post-traumatic stress symptom. It was found that in the restrictive model, around 30% of the patients had post-traumatic stress symptoms, whereas in the flexible model, around 21% patients had post-traumatic stress, which was significantly less in the flexible model. And also the mean IES score was also significantly less in the flexible model. Coming to the secondary outcomes, anxiety and depression symptoms, it has found that the anxiety and the prevalence of anxiety and depression symptoms were not significantly different between the two groups. However, the mean depression score was significantly less in the flexible visitation group. Around 8.5% of the patients in the flexible model and the 11.4% of the patient participants in the restrictive model had a concurrence of the symptoms, but this was not statistically significant. The p-value given was 0.08. They also studied the adherence to the implementation of the flexible visitation model. It was found that all among the clusters of ICUs which participated, around more than 95% of them followed the visiting hours policy. And other policies like dissemination of the flexible visitation model policies to the family members, conduction of structured meetings, and staff training of the flexible visitation model also was followed in more than 85% of the clusters. Total adherence to the policy was found in around 90% of the clusters which participated. The sensitive analysis of the study outcomes were also published, which to show the credibility of the data, to adjust for the missing data and also covariates like age, sex, history of anxiety and depression, and study period. It was found that the outcome was similar to the primary outcome analysis, in which a significant benefit was found with the flexible visitation models with reduction in post-traumatic stress disorder. This is a subgroup analysis to find which subgroup benefited more from the flexible visitation model. It dividing the patients into subgroups like sex, age, history of anxiety and depression, patient's vital status, surrogate decision maker role, living with the patient, Apache score of the patient. It was found that among the patients who had length of ICU stay more than 5 days, the flexible ICU visitation model had a greater benefit by reducing the prevalence ratio by almost half as compared to the restrictive visitation model. Coming to the discussion, prevalence of post-traumatic stress symptoms was 21% in the flexible ICU visitation model. The prevalence was reduced by 10.5%. The number needed to treat was 11. That is, if 11 participants were exposed to flexible visitation model, one of them would benefit by having reduced post-traumatic stress symptoms. The mean post-traumatic stress score was significantly reduced in the flexible visiting group with an adjusted mean difference of -1.36. The explanation for the reduction in post-traumatic stress symptoms in the family members with flexible ICU model was higher presence of family members promoted stronger bonds between the relatives and the patients, which enabled them to provide continuous emotional and social support. They also had the feeling of active participation in the care process of their family members, and information from the structured meetings and materials also empowered the family members. It also provided chances for enhanced communication between the ICU staff and family members as they stayed for longer time in the flexible ICU visitation model. This is a study which compared the effect of family authored diaries on the post-traumatic stress disorder in ICU patients and the relatives. It actually studied the effect of a diary which was authored by the family close relative of the patient. It was found that the diary written by the relative reduced the risk of post-traumatic stress symptoms in the relatives by 26% and also in the patients by 11%. The diary had no effect on depression and anxiety. It mainly reduced the post-traumatic stress symptoms, like the finding which was seen in this study we are discussing also. So it showed that involvement of family members in patient care had a positive outcome, and but in this study they didn't control the visitation hours. They only involved the family members in the patient care. Regarding the outcomes related to anxiety and depression, it was found that no significant difference in the prevalence of possible or probable anxiety or depression was found. No difference in the anxiety score, whereas the mean depression score was significantly reduced in the flexible visiting group. This is the results from the ICU visit study. In this, it was shown that the anxiety and depression scores of the family members were significantly reduced in the flexible model, whereas in the long-term follow-up at 12 months, there was no difference. The reason for the no difference which was found in this long-term follow-up was attributed to the lack of continuous assessment at the 3, 6, and 9 months after the intervention, which would have reflected the effect of intervention better than a direct examination at 12 months. And the sample size was not powered to detect the difference in these outcomes. Strengths of the study: randomization was done adequately to balance the baseline characteristics. The allocation concealment was done, which prevented the selection bias. Large sample size of patients were used to which could have enabled in detecting clinically meaningful difference. Though this study did not have specific sample size calculation for this long-term follow-up. Conduct in ICUs at multiple size and broad patient population was included, which would have enabled in generalizability of the study. Data collection was done by an independent observer, which could have minimized the observer bias, and a large effect size with a lower number to treat of 11, which was also consistent among all subgroups. Limitations: this study has a large loss to follow-up, which was about 50%, which has a potential to introduce attrition bias. The authors addressed this by publishing the characteristics of the population which were excluded from the study also. The follow-up of family members at 12 months was unplanned initially, so they did not calculate a separate sample size for this study. So this study has a possibility of being underpowered in detecting the differences intended in the study. The intervention is multifaceted. It's not only the flexible visiting hours, they also receive family member structured education. So it's unclear which component led to the detected differences in the outcome. The study also did not evaluate the time points before 12 months, like 3 months or 6 months. And they also did not follow up the clinical course and treatment of the family members. They just evaluated at them at the single point 12 months. So it was actually not known if they really had post-traumatic stress disorder or not. Conclusion: flexible ICU visitation compared to restrictive visitation was associated with a significant reduction in the 1-year prevalence of post-traumatic stress symptoms in family members.
Uh, Dr. Meenu, Dr. Engineer, will first let us discuss the case before we go for a critical appraisal. Uh, Very well presented, Dr. Minupriya. The thing is that this is a very thought-provoking topic, because in our setups, most of the time, a structured program looking into the health of our mental health or of those caregivers is lacking. Definitely, most of the ICU in our country do not pay that much attention or in a structure, definitely not in a structured manner to this. So before going to these analysis, the result or what is the conclusion, we'd like to discuss few things regarding the unique structure and the analysis done in this study. So, can you tell us about the type of randomization that is done and what is the advantage or disadvantage of this type of randomization?
Yes, sir. Sir, the randomization they have used is a cluster randomization
Can
with stratification.
Dr. Meenu, can you show
Yes, sir.
that slide which
Yes, sir. Yes, sir.
actually that slide is having a very important 4-5 points regarding the randomization, which are all the student must know.
So, Dr. Meenu, just move your screen down. We cannot see properly. Just move the laptop screen a little downwards.
Yes, sir. Yes, sir.
You have
Yes,
the yeah, now it's okay. Thank you.
That your one slide shows just randomization recruitment initial part.
sir. Yes, sir.
So
So
suppose,
they are, yes, sir.
yeah, this is, of course, we understood randomization. They use the cluster randomization. What is the other thing? Suppose simple randomization, suppose it could have been done. So what was the routine method which we do a simple randomization?
Sir, we
You
use,
got my question?
yes, sir. Yes, sir.
They share the cluster randomization.
That's right.
So what is the other thing which we suppose I am not aware about this cluster randomization. Routinely, I just a researcher I do. What is the usual way which we do the randomization, which is called the simple randomization?
Yes, sir. So in simple randomization, patients or individuals are randomized, sir. In cluster randomization, pre-existing groups like an ICU entirely is used as a unit for randomization.
So this type of design of study, so that is very important. Other person could have randomized like, say for just for the understanding, bed number 2 goes to the restricted, 3 goes to the flexible, 4 goes to the flexible, 5th goes to the rest. That is one of the method. That was a simple randomization. Of course, that may or may not be suitable to this type of design. We'll discuss. Just here we need to understand the cluster. Cluster means we completely took the one ICU, another ICU, and then we randomized. That is the one part we understood. Yes. Then the next is the permuted blocks. So that means it is a block randomization. What
yes, sir.
That? If you
yes, sir.
understand.
Sir, permitted blocks means, so among the ICUs, they actually have variable blocks have been used because to predict which ICU will receive which intervention, they have used a variable block sizes, sir. So among the blocks, the distribution of both the groups will be equal, but varying block sizes are used to prevent prediction within the blocks also. Like for example, if for example a block number of 6, if already first 3 have been a flexible model, it is easy to predict that next 3 will be a restrictive model. So by using varying blocks, they ensure that there is less prediction of the intervention which is going to be received by the ICU.
Excellent. And what is the advantage for the block randomization? Why have we not done the cluster simple randomization after that? So sir, why we are doing the block randomization? If you can
yes,
give
sir.
the answer, then it's fine.
Yes, sir. Sir, in block randomization is done to ensure that equal number of like groups, equal number of ICUs have been recruited in both the groups, sir. If we do simple randomization,
for the randomization, but why? Very good. You are answering very correctly. But why the block? If it is there, then all the time we can go for the block. What is the difference when we go for the simple randomization and the block randomization?
Sir, in simple randomization, we might end up doing more cases in one group alone compared to the another group. Whereas in blocks, when we do the cases at blocks,
that is the random. So of course you are near to the correct answer. When your sample size is small, then you'll end up with this thing, especially when your sample size is more than 300, 400. So when you crosses your sample size to 300, then 97% chance you will get a 50-50%. When you toss the coin, and if you are given only 3 chance, then you are not very sure, or 4 chance, you are not very sure 2 or 1. When you are given a 2 chance only, then you are not very sure one head will there and another will have a tail over there. But if you go for the 1000 times, then definitely. So here the small size is there. That's why we want to have a 1:1 distribution. That is the block. Very good. And the last one is the step, because third thing is the now stratification.
Yes, sir. So stratification is
Dr. Ray, you want to say something?
No, that's okay. But I think that normally any sample size which is more than 200, the simple randomization will be okay. If it is a smaller sample size, you have to make sure you have to intervene like this to have block randomization or thing to find out that everything is equal distributed. That is the thing. Yeah. Tell us the stratified randomization.
Yes, sir. So for stratification is done to ensure that some variables which we think that it might confound the outcome are equally distributed between the groups. So for example, in this study, they have used the number of ICU beds are less than 10 or more than 10 has been used as a stratification variable for randomization. So they ensure that if the ICUs with less than 10 beds are equally distributed between both the groups, sir.
Okay.
Because they thought that in ICUs with lesser beds, the implementation of this flexible model would be easier compared to ICU with more number of beds. So they wanted it to be equally distributed in both the groups so that it doesn't become a confounding factor affecting the outcome.
So they initially divide into the different strata and then the randomization among them. So they divided the less than 10 or 10 less than 10, all the ICU. Then they did a cluster block randomization for that. And the more than 10, then again the same way cluster block randomization. And lastly is the sequential, which for 30 days over there and then cool off. Good. I think
We can one thing we can discuss, sir, before going to regarding the subgroup analysis and post hoc analysis or sensitivity analysis. So, what is the main difference? If you can tell all the audience, Dr. Minupriya, when you do a subgroup analysis, what is a post hoc analysis, what is a sensitivity analysis? So that because these are used in this study. Yes.
Sir. Sir, subgroup analysis is before the conduct of the study, before analyzing the data only, they will find some subgroups which they think that might affect the outcome. So according to after the primary analysis of the study, they will also analyze the outcomes with respect to the subgroups to find which subgroup benefited more from the outcome. So that is subgroup analysis, sir. For post-hoc analysis, is, as the name suggests, it's after the study. So the variables which they have missed in the subgroup, which they have found after the study, for that again they will adjust and they will find if that found any difference in the primary outcome. That is post-hoc analysis. Sensitivity analysis is done when this linear models are used to adjust for the assumptions in the data or missing data. So it's basically to check whether any adjustments in the input will change the primary outcome. Since they have used assumption models, they will use multiple ways of calculating the primary outcome and they will find whether there is any change in the primary outcome. This is mainly to see whether the assumption model which they have used was reliable or not.
Yeah, mostly correct. You have tell. So, what is the advantage or disadvantage of using a subgroup analysis or a post hoc analysis?
Sir, sometimes we might misinterpret the data. For example, if the primary outcome would have showed some difference, and if we in the subgroup analysis, we might think that in one subgroup, if one subgroup has shown some positive benefit, we might think that that was the main subgroup which contributed to the outcome. So there is possibility of misinterpretation of data with this subgroup and post-hoc analysis, because it will also reduce the sample size compared to the whole sample.
Yeah. So the subgroup analysis basically it will be give a hypothesis for a further study. You should do the remutation that the subgroup is there and this is not adequately powered to find out the difference. So it will definitely you can go for further studies on the basis of the subgroup analysis. However, the post-op analysis is basically after the analysis you find something maybe equating or equivalent. So too much of post-op analysis either is like not good because that data may be misinterpreted. Only one or two variable if you find out you can go for a subgroup analysis like that. Okay. So anything else, Dr. Jitendra, you want-
So, Dr. Meenu, just for
Yes, sir.
other audiences also there, can you make the conclusion based upon the subgroup analysis finding?
Sir,
In
no.
conclusion, so
Yes, sir.
when we finally we conclude that trial.
Mm.
So say for example, one subgroup showing your primary endpoint is that may be equivalent, but the one subgroup showing a significant kind of in the favor of some intervention. So can you conclude this thing in your study?
Sir, for conclusion, because since the subgroup is not adequately powered to detect that outcome, it cannot be concluded from that, sir.
Just I hold on here. So all the listener must pay this attention. That is the keyword over there. Subgroup analysis is not powered for making the conclusion over there, which may or may not be right. No, nobody can say that. Maybe by chance, it may be a real thing. But Dr. Meenu, in the beginning, the first important statement is this: subgroup analysis is not adequately powered to make the conclusion of that finding, which may or may not be correct, which eventually, and the second part, Dr. Bikash has already told us. Now, for the next, you're making the hypothesis or alternative hypothesis. Now, this subgroup analysis will make the basis for your another study, and now you go for the sample calculation. Excellent, Dr. Meenu, you express it very well, and the same thing happens for the post-hoc analysis.
Okay, sir. Now, Dr.
In
Meenu,
last, once it is finished, then I have a 1 or 2 slides just for the randomized same thing, pictorial
yeah.
diagram. If possible, I'll show that.
So what we'll
We
do,
can
sir?
move forward.
Dr. Meenu, you can go through quickly through the critical appraisal and tell us whether what do
So
you think?
I
Yeah.
think before critical appraisal, just because every our study we divide into 2 parts. One is the, of course, the core research, and the second is the clinical aspect. So tell you, organize, just can you tell me, now you got this study which is showing a significant positive outcome in terms of the stress. Of course, for the anxiety and depression, there wasn't much. Can you start practicing right from the tomorrow if you are policymaker for your institute ICU, or maybe all other institute of ICU connected to you? So can you pass a notice or maybe a suggestion for all ICU to practice in this way based upon this study?
Sir, actually, in this study, the patient population, mean age of the patient population was 60 years, sir. And out of them, only 25%, I'll show the slide. 25%
No, our question,
that is a
we'll
different
discuss
thing.
it.
Huh.
So simple question is,
Okay, sir.
So what Dr. Jitendra
will
is
you
asking?
implement by tomorrow
Yeah,
itself?
please go ahead.
You
No,
just
sir.
pay attention, or
Yes, sir.
let's see, may or may, or you just reject it as a not at all of no use. It's a completely rubbish paper for me. Or you will take more time to this thing is, or you will want to replicate the trial in your circumstances, 4 or 5 things immediately. So does it make us to immediately you can start practicing?
Sir, no, sir. In our setup, actually, for this implementation of this model, we'll need more manpower. And
no, I'm not asking. Let's assume everything, whatever you require, will be there. But first, you will not apply right from the maybe the.
So Dr. Minupriya,
Easy.
what Dr. Jitendra is asking, suppose you are a policymaker for ICU and you read this study. So you have the option that you absolutely reject the study, not use for this. You have a capability, everything is available. You will implement it straight out from tomorrow, or you plan to implement it in a stage-wise manner or some gradual modification and do this. What is the approach you will do and how will you go? Mostly,
Yes.
this is the
Then
question.
explanation we'll talk about
Yeah.
that.
Yes, sir. Sir, first in our setup, we will try a feasibility study so that we'll find out whether this practice is feasible in our setup or not. After that, we can go to a randomized clinical or because this is actually a different new practice, so we have to use first a non-inferiority trial compared to the practice which is already there, which is the restrictive visitation, and after that we can go to a randomized
So,
comparison.
very good. A second step may not be, because this is the little bit, I'll tell you what is the so many variation and so many biases can happen in this type of study, apart from which we are already knowing the hard research based biases. So first, if your feasibility of the study. So let's see, we are purely a science based practice, and once something has come up, so we have to pay heed to it, and then we'll try to it. So definitely what you said on the first step is the feasibility trial and replication of trial is must. We'll discuss what is it. Just one more question over there. Can you suppose I replicate this trial? Can there is a possibility we'll have a completely contrary result in this? Suppose if it written completely contrary.
Yes, sir.
Can
It's
this happen?
possible.
It's possible.
Possible, sir.
Because now coming to the this type of study is the mainly based upon the individual interviewer behavior, their society and their understanding, and the overall society exposed to the a kind of their exposure in the medical practices. There may be a possibility in Indian setup. Of course, there are different ICU, but I'm just giving example. We may get a contrary result. When you allow the family, they become more anxious. They never exposed to such type of a complex medical. They never seen the patients like they are treated in a way which they never assume. Are a significant proportion of the society may be less stressed when they are not having a much information. Even you try to give a more information, probably they may there is a very fair chances they will get more anxious about that. Whereas in this study, so positive outcome is there, the anxiety level were reduced in the participant. There is a fair chances we may land up with the completely opposite. Those who are remain in the ICU for 12 hours with all the intricacies of the ICU practices, they may increase their anxiety level. So that's what I wanted to emphasize on. The generalizability is not just the statistical and the quality of the research. Generalizability, apart from the good quality research, depends upon the what is the feasibility in your setup. Yes, Dr. Vikas, now we can.
No, sir, that's correct. So, Meenu, please go ahead with the critical appraisal and we'll discuss and the other things. Yeah.
Yes, sir. Critical appraisal. The study validity. The research question is relevant and focused. The study design was appropriate for the research question. The participant assignment was randomized. The methodology trial protocol and statistical analysis plan was published before conclusion of the enrollment. The status of blinding and allocation concealment. Allocation concealment was done, but the blinding of the participant was not possible because they knew how much hours they were allowed to be with the patient's bedside. Then the funder was not involved in the design or the conduct of the study. The patient's baseline characteristics were similar. There is a possibility of recall bias since the participants were not blinded, which might affect the post-traumatic stress disorder and the anxiety depression scale evaluation since the scales had components which were subjective. both the groups receive the same level of care.
Here, Dr. Meenu, just
Yes,
go
sir.
back. The bias
Yes,
is, they mentioned the recall bias, but I feel there is a chances of individual behavior bias also. The same level of this thing is one personality is a different from the another personality. In one personality, some amount of the information and situation may produce a stress, another personality may not. And the interviewer given in their response in that way also. So there is an element for this thing is. Second is the situational bias. Situational bias means a near short term. Do you understand? Near short term is like a quote is there: do not promise when you are happy and do not decide when you are sad. Suppose the same interview day, what happened to that particular interviewer one day before? If something wrong happens in one day before, negativism is there, so that time of response cannot reflect maybe original response. There is a possibility over there at that moment in the near short term, how he is exposed to otherwise in their life. So they may have a response to the interview which is a little bit maybe a different from the his basal level. So that was not mentioned in this study, but that is possible. Yes, we continue.
Results, sample size estimation and power calculation were mentioned for the ICU visit study. It was not done separately for the study though. The statistical tests were mentioned. Outcome measures were properly defined. Confidence intervals were reported. Dropouts and missing data were there, but they were negligible and they were accounted for in the assumption models. Generalizability, the study limitations were discussed. The study result to be applicable to the local population, yes or no? My answer is no, because the reasons we discuss now, because the family members in Indian population are different from the family members in this study, where they had around 30% of them had higher level of education, and their income status were also upper middle and lower middle compared to the population of family members in our ICUs.
That is one thing, Dr. Minupriya, but as told by, they have in their study, they have mentioned the educational level and the family status of the relatives. Even with that, if you want to replicate that, another main aspect that Dr. Jitendra told is that the behavioral pattern of our patient, our relatives, because of our understanding as a medical field of a society, or the customs or the beliefs that we have. So it will be take a lot of things, a lot of confounding in our society and our society also. And as I told you, if you have to implement also the manpower requirement to all this, or to produce a structured program accounting all these aspects that might affect, is also much more important.
Yes, sir.
Sir.
So at this stage, definitely what is importance of this paper is it gave us idea that is one of the way to look at. And as you clearly put the no, because the people may say yes in this circumstances, but definitely as if now this study generalization, no. What is the next step? Definitely it gave us to idea about to really think of it with the open mind. We may not have this type of result. There is a possibility we may have a contrary results. We have quite seen quite often the certain, and it may be a variable from the one, because we are having a very heterogeneity in the medical services also. So one population remaining with the even in the ICUs and the exposure to the so many detailed knowledge about the care makes anxious the family member. So rather it may be other way now.
Another
So
thing, yeah, yes, sir.
yes.
Yeah. So there is a previous study you discussed, Dr. Minupriya. Only one RCD was there who look at the mental health of the caregivers, and now
Yes,
you
sir.
have the study. So if you combine both the studies and you know the result of the both the studies, and if you plan to plan another study for today regarding the mental health of care, what should be your study, or what is the focus of the study based on the result of the previous and this study? So in the previous RCD, they have only looked after the short-term
Short
games.
term, short
Here,
term.
it's a long-term game.
Yes, sir.
what is the inference you have with both the results, and if you plan another study, what should you focus on?
Yes, sir. Sir, actually, it should be a continued follow-up, sir. Sir, just like sir told, their mood on the previous day also could have affected the outcome, since they looked at the outcome only at 12 months. So, if we had followed at the family members at fixed intervals like 3 months, 6 months, and we could have predicted their response. It could have other factors like this. Patients, family members' mood and all would have not become a confounding factor, sir. So we could plan like continued analysis, assessment of the family members at regular intervals.
Yeah,
Dr.
it seems
Meenu,
like
can you read in between the line of, when I say in between line is, can you sense this study? Because of course I may be wrong, but when you see whole paper, can you read in between line what happened to their investigator here? I
What?
feel whatever they make their analysis conclusion, they never planned in that way.
Yes, sir.
Even a 50% dropout, and in the restrictive more than 50% dropout, though you explained for that, that doesn't carry any meaning. Suppose somebody make us some outlier thing just for the comparison, some make us some crime, just justification cannot reduce the crime. Similarly, the more than 50% dropout, I feel it's a completely off official over there. Maybe some other plan for the investigator. They plan and all these things, and they change in the drastic way over there with the 12 months and the 50, because 500 something, 528 or 533, that was the initial randomization. Even intention to treat, the whatever we analyze is the per protocol analysis only. They
Yes, sir.
make some correction, but it's not the truly intention to treat analysis, because so much large number is completely dropped out. Though there's a soft kind of results, that's why we cannot suppose this is the same design and same thing happens to us, some core medical results where the same maybe a drug trial, maybe a procedural trial. Nobody even dare to publish such type of trial where the your control group is the more than 50% and the intervention group is somewhere 48-50% dropout is there. So it looks like, and I don't know, what is your opinion, Dr. Vikas?
yes, sir. They are not planned this. Definitely, it looks like they have not planned this, and they have done it in a manner. But as shown in the result, there are a lot of lacunas because you have not a continuous data. So this does not give you an idea. If you combine both the studies, in the previous study, there is only short-term problems are there. That are the depression and anxiety, which are not present here only. So ideally, as a physician, I would like to know okay, what if there is only short-term intervention are present, for how much duration, whether they require any intervention or not. Similarly, here also, whether they require any intervention or not, they are not at rest. So, whether the long-term effect are how much and whether they require intervention. So, maybe properly designed study in the future give answer to these things. But currently, they are this is something which they made up in between or at the end of the study to find out these things. It looks like that.
That excellent presentation and good critical analysis with the meaningful way rather than stereotypic kind of this thing. Before can I
Yes, sir. Your
share
slides.
just
Yeah.
one or two slides
Yes,
just
yes.
to
Please share, sir. Stop.
I stopped.
Yeah.
slide visible?
Yeah, just go full screen, sir. Okay.
Okay. So this is nothing but what we discuss, and Dr. Meenu very clearly explained about this thing is, of course, today's and our trial is not the adaptive, so we'll not go for this complex randomization adaptive. Adaptive word is the typical, you can say, as per your convenience, you keep on changing the rules of game. So just the fixed is the when the difference between adaptive and fixed is the once we do a randomization initial before the beginning of the trial, and then adaptive is you keep on changing your stand. That is a little bit a kind of a more complex. So why I selected this slide? Because in this study, this part is actually used. The simple randomization as I just tossing the coin and the overall kind of this thing. Dr. Bikash made it very clear. 200, my impression was somewhere 300, but okay, for at least 200 and more than 200, then only you are sure you can go for the equal distribution among this thing is. That is the block and stratified. What is actually, so this is the block. Rather than overall your sample population, you take the block out, and that block itself is a randomized. What does it mean? 4, 6, 8, 8, 4, 4, 4, 8, 4, 8, 4. So that this block keep on randomization is not completely randomized, because sometime there may be a complete, sometime a few allotative will have a direction. Say for example, initially by chance, initially you randomize 3 and they all are in the intervention group. Now you have to keep next coming 3 in the control group. That is the one situation. And of course, that's why it is not, and then this block itself is a randomized. Sometimes you take 4, 4, 5, 4, 4, 6, 4, of course, in the not in the odd numbers. And then so that it will ensure your 1:1, especially when sample size is the small. And this is a stratification. Say for example, in this trial, this square is more than 10 beds and the round is the less 10 or less than 10 beds. So rather than taking this thing is, you take all the 10 beds away, all the more than 10 beds away. Now you make the blocks and then randomize. So that is a part. And the second part here is a typical, once we randomize and then we keep on doing the trial. In this trial, this also we can see. So randomization happen here. Your intervention group, now 30 days of wear off or cooling off, so that whatever effects happens and those patients will remain discharged or mortality, whatever happened, now from the fresh beginning here. So those ICU who were initially in the restrictive group, now they will become a intervention group, that is a flexible. And those who are the initially flexible, so that is your duration of their study period. This is your cooling off or wearing off period. And then again, the same ICU eventually will be exposed restrictive and non-restrictive. First step, they will be randomized. And the next step, definitely after 30 days of this thing is, they will be allotted to the another. So that's all actually. Somehow I find the slide relevant slides so that.
Yes, sir. Okay.
So you can close if you have finished.
Yeah, thank you, sir. So, Dr. Tapis, I think.
No, I think wonderful. I have nothing to say. Beautiful. So thank you, Dr. Minupriya. Very well presented, very nicely answered. Best wishes for your exams and career. And once again, thank you, Dr. JEETENDRA, sir. Sir, can you close this thing?
Stop sharing.
Let me see if I can put it on my end.
I don't find this. If you can.
So there will be the green one. Yeah. Yes.
Okay. So thank you, sir. Dr. JEETENDRA Sharma, sir, very nicely as usual, and Bikash, sir, wonderful. I think we have done a very nice analysis, and she has answered very nicely, presented very nicely. So should we close, sir, till the next time?
Yes, sir.
Okay. Till the next time.
Thank you, Dr. Bikash. Thank you, Dr. Meenu.
Thank you, sir.
Thank you, sir.
Thank you, everybody. Thank the audience for their patient hearing. Thank you, everybody.